Good morning. This presentation about the encroached base is about Mr. X, who is a farmer from Kadapa, presented with a holocranial continuous headache since 20 days, the low-grade fever of 20 days, weakness noted over the right upper and lower limb since 7 days, with a difficulty to verbalize since 2 days, but with 2 episodes of seizure. On elaborating further course of his illness, on the last week of the December, he had some low-grade fever with headache and 1 episode of vomiting, for which he was evaluated in nearby hospital with a CT-PNS on January 3rd, which revealed as sphenoid sinusitis, for which a FIS was done. The immediate post-operative period was uneventful. Then on day 3 of the surgery, he developed a fever, headache, and a weakness over the right lower and upper limb was noted. And he also developed 2 episodes of seizure on day 7 of the surgery. Regarding his past history, he was a newly diagnosed diabetic mellitus with an uncontrolled blood sugar with HbA1c of 12. So with this syndrome complex of sudden onset right hemiparesis and with language dysfunction and new onset seizure in post-West period, he was examined, which revealed a BP of 140/90 and with a pulse rate of 90 per minute with respiratory rate of 16 per minute. On observing his DCS, it was E4, V aphasic and M5. On examining a CNS revealed he is aphasic but oriented to persons. And the cranial nerves examination revealed the deviation of angle of mouth to the right and with a weak gag. His motor system examination showed a power of 3/5 in the right upper and lower limb with the brisk reflexes over the right side and a plantar response being extensor on the right side with a normal sensory and cerebellum functions. Other systems examinations were normal. So with this, we had a differential diagnosis considering his short course of illness following a surgery with the CT-PNS done already outside. We thought of a partially treated sinusitis, which has led into the further complications as meningitis or ischemia leading to cerebrovascular accident and a skull-based osteomyelitis. And we investigated him, which revealed his HbA1c of 12, and when cultured, his blood revealed no growth. Considering his meningeal features, we did a CSF analysis which showed increased counts. And culture nasal swab was done, which had no growth, but nasal tissue grew in a broad aseptate hyphae. This is a representational image in which a broad diamond-shaped aseptate hyphae is noted, suggesting mucor. CT-PNS was done, which revealed features like soft tissue thickening with irregular lytic area in the clivus and bilateral petrocleval region, suggesting feature of skull-based osteomyelitis secondary to sphenoethmoid sinusitis with intracranial vascular complications, which was elaborated further in the MRI study that showed features of acute infarction in the left high frontal, left parietal and occipital regions and the medial aspect of the left hemipons, and features of central skull-based osteomyelitis secondary to the sphenoethmoid sinusitis. So skull-based osteomyelitis in this patient with a fungal etiology, it is the inflammation of the skull base resulting from the infection from the neighboring tissues. Probably it can be differentiated as otogenic and non-otogenic causes. And the most common being the otogenic, but in our patient it was a paranasal sinusitis. Other common causes are chronic mastoiditis and odontogenic infections. Most common presentation usually is cranial nerve palsy. The organism, fungal organism causing Candida aspergillus mucor. Risk factor is uncontrolled diabetes and severe anemia. Other than that, bacterial causes are also elaborated, like Pseudomonas aeruginosa, Staph aureus, Staph epidermis, Salmonella species, such bacteria. And the bone involved are frontal, sphenoidal, temporal, and occipital. So, in this retrospective cohort study done in our institution by our eminent professors, revealed the most common presenting complaints of a patient with a skull base osteomyelitis will be headache and fever. Our patient had headache and fever, and the risk factors elaborated were diabetes mellitus. Our patient is a diabetic with uncontrolled sugar levels. And also the complication noted in that study was mostly cranial nerve palsy, meningitis, cerebral infarcts. Our patient had these three complications. And also in one another study which linked the risk factors to the probable source of infection in skull base osteomyelitis. Diabetes mellitus, patient with diabetes had gained the infection from the paranasal sinus infections. And this is one another study regarding the management of the fungal skull base osteomyelitis and mucor due to mucor. In that, antifungals, amphotericin B and azole posaconazole, and amphotericin B and echinocandin combination therapy, ion chelation therapy were studied, in which amphotericin B as a single drug leads to better recovery. So, in our patient, he is receiving intravenous conventional amphotericin B 1 mg per kg per day, 70 mg, with plan for surgical debridement of the source, and will control over the blood sugars and the treatment of the other complications, and he is quite doing well. So take home points are, in a patient with sinusitis who presented with CVA, a possibility of angioinvasive organism based complication should always be suspected, because prompt diagnosis and culture guided therapy and early surgical debridement is essential for good clinical outcome. Thank you.
Thank you, Dr. Sivaranjani. Are there any questions from the audience? Thank you.
Thank you.
Okay, if there are no further questions, we come to the end of today's clinical meeting. Okay, so moving on to the presentation of the day, I think we had both the hypokalemia cases I thought were very interesting. We saw both spectrums of hypokalemia with hypertension and normotension. So I think it will only be fair that I share the award between John Roy and Christina for their presentation. With this, we come to the end of today's clinical meeting. Thank you.